Hello, everyone. My name is Dr. Fergal Armstrong, and welcome to this episode of Cracking Addiction. And we've got with us today Dr. Manu Bagar. Manu, I believe that we're going to talk today about psychosis. What is psychosis?
Well, I think we'll end up having more debate about what is psychosis than we began.
Mm-hmm.
I think in the context of the word, I think it's important to simplify it as a disturbance in thought, perception, or cognition, and often all together. And psychosis is a symptom rather than an illness by itself. And I think there are many permutations and expressions of psychosis because they're founded upon one's individual past experiences. So your previous
Mm-hmm.
traumas and your previous experiences based in reality in a psychotic experience can be compounded for perceptual disturbances, so visual hallucinations, auditory hallucinations, thought disturbances, which is delusions, paranoia, and alterations of cognition, which is often a distorted perception of reality as it goes to what's happened to you in the past and maybe real life events that haven't yet happened. So that constellation of symptoms can be very different from each individual. And you might have all of those experiences, you might have just one, and it might be really imperceptible to someone else, or it might be pretty bloody obvious to someone psychotic. But I think something to understand is that it can happen in the context of substance use and be very short-lived, or it can be something that people experience for the rest of their life as well.
So there's a lot in there, and I really like your summary of the diagnosis of psychosis, this disorder of perception, thought, and cognition. And I also like the fact that you say that it can be due to a range of other conditions, and it in and of itself is not actually a disease or a diagnosis. It's a kind of a cluster of symptoms. So it doesn't
Yeah.
tell you, the word psychotic or psychosis doesn't actually tell you what's actually causing this disturbance of perception, thought, and cognition. So I suppose, one of the issues that I've got that I frequently think about is, to what extent does social context influence the diagnosis of psychosis, or cultural context?
Yeah, quite a bit. And there have been many studies, many psychiatrists have wondered this throughout time. One thing to consider is current trends in society,
Mm-hmm.
understandable natural fears that exist in the news can be sort of kindling for the mind to be fearful and paranoid upon. For example, when televisions and radios first were invented, there began this huge wave of people thinking uh, other forces, other entities can listen to them or are in fact communicating to them. That still exists, and that idea of thought broadcasting or thought insertion, the literature would suggest is a relatively new phenomenon. There is not a lot of evidence that that existed prior to the year 1900, and I think it's quite evident that psychosis did exist before then. When glass and mirrors were first in fashion in Victorian England, a lot of people had what we back then called glass delusion, where they were thought they were made of glass. They would break apart if someone hurt them. And then more recently, it's phenomenons like what's in the media and TV and film. The show Truman Show came out, and to this day, you still see people have their first episode of psychosis or first experience of psychosis believing they're trapped in a TV show and everyone's an actor and they're watching them. So not only
That's
what's
also
happening,
the Matrix.
yeah, quite right. And
Yeah.
who's to say who's psychotic and who's just aware of the truth? But what we do see in current trends of news and media and also fiction, definitely fodder for your brain to think that might not be too far fetched.
Mm. There's Let's talk about the causes, the potential causes of a psychosis. Talk us through your understanding of that.
Yeah, I think it's something that we now understand is quite varied. So there isn't often one thing that we can point to say that's why you became psychotic. Now, this is where the terminology becomes really important, and there's been a lot of attempts to unify terminology of psychosis across countries and across languages as well. For example, psychotic experiences can be a lot more common and may not indicate a psychotic episode. So very similar terms and can be interchanged but mean very different things. So for example, if someone were to inject methamphetamines, they would be about 60 to 70% likely to have some sort of psychotic experience while they're intoxicated. And that could be as mild as paranoia, but it could be as severe as perceptual disturbances and poor reality testing. But generally what we expect is when the intoxication wears off, so does the psychotic experience. So in that case, the substance was clearly the causative agent for the psychotic experience. But if that psychosis lasts beyond the intoxication, the expected time in which the substance is running its course, we call that a psychotic episode. And that could be anywhere from a few days to a few months. Those psychotic experiences may vary across that time period, but that absence of reality testing and some sort of vague paranoia or disturbance in perception exists. And that's when we start to think, is this more than just a substance? And is the substance something that has precipitated or triggered the psychotic episode? The cause for why that happens to some people and not others is quite varied. And that's what we would term a first episode psychosis. The idea is that psychotic episodes represent maybe a vulnerability to developing psychosis that could be genetic and environmental, and it could also be a long-term consequence of chronic substance use. In a way, through neuroplasticity, recurrent use of methamphetamines or cannabis, for example, can be shown to cause sort of something like a static picture of psychosis if you have multiple episodes of it. But sometimes it's helpful to think about a psychotic episode or a first episode of psychosis as a cup. So if you can imagine a coffee cup in front of you, it's empty when we're born. But if you have a genetic predisposition to psychosis, for example, if you have a first-degree relative, a parent or a sibling who's had schizophrenia, you could be anywhere from 6 to 12% likely to have schizophrenia yourself. So if you do have a first-degree relative, you're inherently born with a cup that's a little bit full already. Then the environmental influences put more into that cup. For example, we've got really good evidence now that the earlier you start smoking cannabis and the higher the quantity, the more likely that cup is to become full. Reactions to stress, high expressed emotion in the family. So EE, high EE expressed emotion, is a term used to describe a family environment where everyone kind of just says what's on their mind, and there's a lot of stress and chaos within the family unit. And that expressed emotion has been linked to a vulnerability to developing psychosis, as well as other mental health conditions. There are even some really interesting studies that have been done in the past where may not be relevant day to day, but some studies have pointed to the fact that if you're born in the Northern Hemisphere in winter, that is also somewhat of a link that makes you vulnerable to developing schizophrenia or a psychotic episode later in life. So a lot of these things we can't control. Genetics and what time of year you're born are completely out of your control, but others you can. And so that's where we break it up into the static and dynamic risk factors of developing psychosis. Ultimately, if you have enough in that cup and it overflows, that's what we think is a first episode psychosis. And that's where all of these risk factors have compounded and gone out of hand to make that vulnerability exposed. But just as if that cup overflows, we can do a lot of things to prevent it from happening. If you know you have a genetic predisposition to schizophrenia, then you're more likely going to have a psychotic episode, and a first episode psychosis. Probably staying away from substances is the best way to limit how much is in that cup. Adaptive mechanisms with stress and stressful environments are really beneficial. Lifestyle modification is really, really important. And just as we can prevent it, once someone has had a first episode of psychosis, all those factors are relevant in discussing prognosis and limiting relapse rates when someone is diagnosed with first episode of psychosis.
You're an addiction psychiatrist, and your special interest is, dealing with the effect that drugs have on mental health. So let's try to hone in on the specific issue around the drugs that actually can cause psychosis. So what specifically, what drugs do you think are implicated in, as you say, those dynamic, non-static risk factors for the development of first episode psychosis?
I think the most prevalent and potent one that we're finding is stimulants. So that would be methamphetamine. Injecting, like I mentioned, that experience of psychosis is so high when someone injects a reasonable quantity of methamphetamine that it's bound to flip a switch if you're genetically vulnerable. The one that's been studied the most is probably cannabis, though. And I know cannabis is, firstly, a lot more prevalent, a lot more accepted, even used for medicinal purposes, and that's not without merits. But I think something to keep in mind, if you do have a vulnerability to psychosis or a past history of psychosis, you might not get prescribed cannabis, and using cannabis off the street was probably going to cause more psychotic symptoms. Like I mentioned, heavy use early on in life with cannabis fills that cup in to make you more likely to have a first episode of psychosis.
It's interesting you say that, because I've also read a paper, and admittedly, we can argue about the various types of evidence bases that we've got, but I have read a paper that suggested that if cannabis per se was used in the absence of any other substance, that the numbers of de novo psychotic episodes that occurred in a cohort, I can't remember the total number of the cohort, but it was in its thousands, is actually only 7 cases. So that's not to say that cannabis-induced psychosis doesn't occur, but I suppose I'm stirring the pot a little bit and asking you to what extent is cannabis causing the psychosis or unmasking a psychosis?
Yeah, I think that's a very valid point, and just putting the evidence aside, because I've heard and seen both sides of the coin here. In my personal experience, it's quite rare for me to see someone having cannabis trigger a psychotic episode, just in the way that stimulants can do that. It's more that slow build up over time. And a typical scenario you'll see for, if you're having done a job in first episode psychosis, a typical scenario for a young man, 18, 19 years old, for having the first episode of psychosis is this 6-month period of a prodrome where they're not really engaging in social activities. They're very blunted in their affect, and that can be for about 6 months. And often what happens is there's this history of smoking cannabis prior to that. And it sort of creeps up. The psychotic experiences don't technically happen with high amounts of cannabis use night after night. It's that it sets off this cascade of psychosis developing first through a prodrome and then through slight delusions and perceptual disturbances. And I think the evidence with cannabis is less about psychotic episodes and psychotic experiences, but schizophrenia. It's really important to understand that schizophrenia is a syndrome of various symptoms. The hallmark, and the one that's most concerning, happens to be psychosis, but you also get a myriad of what we call negative symptoms, which is blunting of the affect and alogia and avolition. And I think all the research that suggests that you'll develop schizophrenia is likely because of earlier heavy smoking. But I agree with you. In my clinical experience, in my addiction psychiatry career, haven't really seen someone who's had a bad night of smoking weed and then has a really bad psychotic episode. Definitely nowhere near as much as methamphetamines or hallucinogens.
So there's a couple of key issues here that we need, I think, to explore. So really, the difference between psychosis and schizophrenia is that psychosis, as we've already agreed, is a kind of a group of symptoms, i.e., as you've described, a disorder of thought, perception, and cognition. But it's also these negative symptoms. And you've mentioned a number of words. I think perhaps for the sake of an audience that's less psychologically minded than we are, perhaps we could explore exactly what those negative symptoms might mean to the layperson.
Yeah. I remember them by the 4 A's. I'm sure there's a fifth A, and I'm forgetting it, but the four A's that definitely happen in the prodromal phase. So sometimes people with schizophrenia have the negative symptoms before they start to have psychotic experiences. And it can be really difficult to tell, but the four A's are blunting of an affect. So blunting of affect means that the person who's experiencing these symptoms, if they hear a funny joke, they will understand that it's funny, but on the outside, you won't see them laughing. And so their expression of emotion is blunted. It's not meeting halfway between your expectation and their expression. Alogia is a lack of word production. So people will often find that they can't communicate their thoughts very well. Avolition or amotivation is exactly what it sounds like. So a lack of willingness to do things that would otherwise be necessary to be functional, like getting up out of bed, showering, going out of the house to see their friends. Let me go through it again. Blunting affect, alogia, avolition, asocialization. People with schizophrenia tend to have a lot of interpersonal difficulties. It's interesting to split hairs, but sometimes that can be because of the psychotic experiences. The paranoia and perceptual disturbances can impair wanting to go out and trust someone to talk to. But there is also an inherent lack of will to do things in social settings, and lack of yearning to socialize, which you would expect that most people would want to do. And the last one is attentional deficits. So the neurocognitive effects of schizophrenia are sometimes the most debilitating part of schizophrenia. So having an episode of psychosis where you're hearing voices and paranoid and delusional, we've sort of gotten pretty good at keeping that at bay after it happens. But the thing that we really struggle with in psychiatry is giving people that attentional improvement after an episode. So chronic schizophrenia is really, really difficult to treat fully because those negative symptoms and the attentional deficits that arise can be really difficult to get someone to, want to do the things that will functionally make them integrate back into society. So those are the five symptoms, negative symptoms.
So really, to simplify it, then we have to think about schizophrenia as a collection of positive symptoms which are characterized by psychosis, and a collection of negative symptoms which you've elucidated as the 5 A's and you've gone through. And that's in contradistinction to something like drug-induced psychosis, where you have really a kind of a short episode of the presence of those psychotic symptoms. But on the other hand, there are other mental health conditions that kind of look like the negative symptoms of schizophrenia. And I was wondering, for instance, depression, a good going major depressive episode or major depressive disorder can produce a lot of those negative symptoms. So would you comment on that?
Yeah, definitely. And I think that's where the folly of cross-sectional assessment is something that we all get stuck in. And I think that's a typical scenario of a 20-year-old who's smoking cannabis, has had 6 months of these symptoms, and you could pick any one of chronic cannabis use disorder, major depression with severity, first episode of psychosis, some other acquired brain injury. All of these differentials are really important to keep in mind before jumping the gun and saying this is depression or this is psychosis. But they do share similar symptoms and also similar neurocognitive underpinnings. Obviously, the extreme end of major depression with severe symptoms is depression with psychosis. And so, if you remain depressed enough and for long enough without treatment, psychotic symptoms can develop as a part of depression. There are some specific hallmarks of psychotic depression, but I think it's really important to keep an open mind and do a thorough history first time you're seeing someone with this constellation of symptoms, and also think about what prognostic factors could lead to someone having their current presentation. For example, if they've got a genetic underpinning to schizophrenia or bipolar affective disorder, that can be a strong hint about what you're seeing in front of you now. responding to antidepressant medications. Often people with a first episode psychosis are commonly mistaken for having a depressive episode, and you just won't get any better with antidepressants or conventional treatments for depression. There is a lot of grey area, and I think sometimes retrospectively it's easy to say, well, that's what it was all along. So that's why it's really important not just to have the medical model when someone's experiencing a relapse of depression, psychosis, substance use, but rather to have a supportive model where a longitudinal assessment can be formed, and a psychiatrist or a medical professional can utilize that collateral information to see what the time course is.
And of course, that longitudinal assessment really is crucial in understanding the different presentations between major depressive disorder and schizophrenia, for instance, where schizophrenia is characterized by this progressive, unremitting decline in function, i.e., the accumulation of negative symptoms, whereas major depressive disorder is by its very nature episodic. So you get better. You might relapse, but in between the two episodes, your function is not impaired. Would you care to comment on that?
Yeah, definitely. Some people, major depressive disorder, some people are of the opinion that it could be a bipolar affective disorder, just waiting to have your manic episode. So, of course, bipolar affective disorder is very debilitating, and you have severe episodes of depression, but the hallmark of bipolar affective disorder is you also have a manic episode. The lows of bipolar are very severe and often the thing that is most debilitating. And I think there are a lot of people out there who have major depressive disorder, and the severity of their depression is just as severe as that bipolar type picture.
So really the episodicity of the mood disorders longitudinally distinguishes those mood disorders from the schizophrenia disorders.
Definitely. And the interepisodic functioning. So the goal of treating someone who has had a major depressive disorder is getting them back to working and being a parent and integrating back into society. And all the evidence that we have is if you do that well and continue preventative measures, biological treatments like antidepressants, psychological therapy for quite a while, adequate social support, so you can really get someone back to functioning and prevent an episode for quite some time. But with schizophrenia, we're really sort of, at the moment, capitalize preventing psychotic relapses, which means preventing the positive symptoms from having a big hold on people, because that can be quite debilitating and scary, and that's where people often need a hospital admission. But in between that, the negative symptoms still are really difficult to treat, and conventional medications for schizophrenia aren't very good at treating negative symptoms.
Yeah. So again, let's bring in the discussion back to the concept of drug-induced psychosis. So, we've agreed that methamphetamine and cannabis are the two main culprits for the actual diagnosis of substance-induced psychotic disorder. Are there any specific hallmarks of substance-induced psychotic disorder that you would rely on to help you distinguish that disorder from either a schizophreniform or a schizophrenia disorder, or for that matter, a brief psychotic disorder, and also the mood disorders? Because it can be very confusing when you see a patient for the first time presenting with psychosis, especially in the context of addiction.
Yeah, definitely. And look, I think the amount of substances one has used prior to having that first episode of psychosis, and also the physical health at the time that they're experiencing that is really relevant as well. What I commonly see, especially with stimulant medication, is a psychosis has this component of psychomotor agitation that sometimes you don't see with an episode of psychosis where schizophrenia is the underlying cause. And what I mean by psychomotor agitation is this intense drive to act upon the psychosis. And, looking at someone from the edge of the bed, even if they're not saying anything and explaining their psychotic symptoms, you'll be able to see that they're psychomotor agitated by this internal restlessness and a need to communicate and act on a lot of their psychotic experiences. Again, it really is person-to-person dependent. There is some evidence that the nature of delusions can give you a bit of an inkling about whether it's drug-induced psychosis or an underlying schizophrenia. So, for example, people with schizophrenia, their psychotic experiences can often be called systematized delusions. So it's not just that people are listening to my conversations and I'm a bit paranoid on edge. It's a lot more fleshed out, and there's specific people in a conspiracy, and it goes up to the CIA, and it's really, really ingrained in them. Because if you do think about it, they've had a lot of time to establish this delusional network. Whereas often I see people who have had an abrupt, precipitated psychotic episode. It's largely the hypervigilance and being on the lookout for threats that comprises the paranoia and other psychotic symptoms.
So it's more inchoate, less formed, less, as you say, systematized.
Yeah. But, fleshing that out can take a while, knowing what's happening in the short term and what's more fleshed out and systematized is really difficult.
The other thing, I suppose, is to emphasize again that the longitudinal assessment that is so useful in distinguishing the schizophrenia disorders from the mood disorders is also equally important in distinguishing the substance-induced psychotic disorders from the schizophrenia disorders, because with abstinence, you would anticipate a resolution of symptoms, wouldn't you?
Yeah, definitely. And that's where it becomes really hard in the community as a GP, psychiatrist, addiction specialist to say, is this schizophrenia or is this drug-induced psychosis and someone's continually using substances? And, try as we might, you're in drug screen, trying to take a good history about how much someone's using, there really is no way to ensure that someone's substance-free. And often a period of hospitalization, or often, some ways that I know is if it's schizophrenia or intoxication, drug-induced psychosis, if someone's had an episode of incarceration, if they've been in prison and still had psychotic experiences, then you kind of have a think about the diagnostic framework, because obviously you assume there wouldn't be as many substances in prison, and schizophrenia becomes the more likely explanation. But, it is difficult to know.
But that assumption sometimes is a dangerous one to make, because it sometimes is not the case that someone is guaranteed to be abstinent of drugs whilst incarcerated.
I'm sure
we have to acknowledge that.
Yeah, no, definitely.
Yeah. All right, Manu, look, I really want to thank you for your expertise today in teasing out the diagnostic conundrum that is psychosis in the context of addiction and substance use disorder. Many thanks for your pearls of wisdom.
No worries, Fergal. Happy to help. See you soon.
That's all for today, folks. My name is Dr. Fergal Armstrong, and this has been Cracking Addiction.